Thank you for joining us today. We're super excited to have this webinar. So, Chad, why don't we go ahead and just kick it off? Let's get started.
Sure.
This should be a really great 30-minute conversation just between us. Just about the great things you guys are doing in Mississippi and the Rural Health Alliance and all of that. So I'll start off by saying I just want to say welcome to everyone that is joining us today. We are currently on our normal webinar platform, but also live streaming on LinkedIn. So this is a first for us. So Chad, you're famous.
Oh no.
Just want to thank everyone that is joining us for the first time, and those that join us every month for our monthly webinars. My name is Anthony Velasquez. I'm the Chief Product Officer here at PharmaForce. We are a 340B third-party administration provider in the 340B space, working with entities all over the map, from clinics to rural health hospitals and providers, and hospitals and IDNs throughout the United States. These monthly webinars our goal is to provide value to the 340B community. At the end of this 30-minute, I want you to feel like you didn't waste your time, like you learned something new, like you learned something valuable. And that's my goal every time that I do one of these. We do record them. We do post them on our YouTube channel. We do email the recording and everything out. You go on our website at thepharmaforce.com /webinars, and everything is there that we have done for the last several years. But let's jump into today's guest, because we have a very special guest today, a very special topic. And Chad, before I introduce you and allow you to give us a little bit about of your background, what I want to do is I want to paint sort of the picture of where we are in the 340B space currently. We are at a time, I've been in the 340B space for, I want to say I'm going on my 14th or 15th year now or something like that. There's definitely been a while. But we've been through, some of these ups and downs, right? So I've been through the time of the fear of the mega guidance that was supposed to significantly change the 340B program. We've been through the time of the ramp up of HRSA audits that were events that were, had covered entities very concerned about compliance and the 340B program, the future of the program, the scrutiny on the program, and things like that. But we've really entered just a completely different atmosphere as it relates to the attacks on the 340B program, the understanding of the value of the 340B program. And I really want to use this time to clarify the impact of 340B on rural health communities, the impact of these manufacturer restrictions on rural health communities. So let me set the picture. We are now at 36, 37, they change every day, but 36 or 37 different types of manufacturer restrictions that continue to evolve and are in this kind of just a wild west of manufacturers passing on restrictions on covered entities of all different types. There are, at this moment currently, I want to say there's 4 or 5 different bills in the federal government, both in the House and some in the Senate, related to the 340B program. There are contract pharmacy access bills across, I would say, 3/4 of the states in the US that are now being that have passed, right? And you have a successful story to share with us today, that are working through their progress of being passed or being considered, or are facing some sort of challenge and some sort of pushback, right? So, we have kind of like these parallel buckets of enormous legal battles going on in the 340B space, and I've been talking about this for months now, and helping everyone understand and kind of keep up with what's going on. So that's the background that kind of sets a foundation for where we're going to launch our conversation. So Chad, you're the Director of Rural Health Alliance and for the Center for Rural Health in the state of Mississippi. I want you to please introduce yourself, give us your background. I know you share a little bit with me, but I'd love for everyone to know here that you're really coming from a deep expertise. But tell us about your background in 340B, the work that you guys do at the Rural Health Alliance, just the work that you're doing on a daily basis with rural health providers.
Sure. Currently I serve as the director. It's actually the Rural Hospital Alliance.
Yeah.
So I serve as the director of Rural Hospital Alliance, and as you mentioned, the director of Rural Health Policy for the Mississippi Hospital Association. I've been in this position for 2 years. Prior to that, I served at a critical access hospital in Southwest Mississippi for 25 years. Probably the last 14 or so of that I've served as the CEO. Introduced to 340B, oh gosh, I guess prior to 2008 or so. And we in a critical access hospital really just trying to use it in our outpatient setting. Weren't very successful with it. Was introduced to the idea of using contract pharmacies, and it was just so overwhelming to us, and didn't have a lot of resources being in a small rural hospital to really go out and understand how to utilize it. Tried to work with our local retail pharmacists, and they unfortunately had less understanding about the 340B program than we did. So it was really a program that we knew a little bit about, knew that the opportunities were there to help our patients, and to bring some additional savings revenue to the hospital. Just didn't know how to fully access that program. After 2008, but found the right people, if you will, began to learn more about using the contract pharmacy, and really moved into that space, and really in our community began to fully see the benefits of the 340B at the patient level. Because now you are helping people, access their needed medications to help them maintain their chronic conditions, because they have access to affordable drugs at that time. So it was exciting to see that from a patient perspective, and as well as the hospital perspective. As we moved along in the process, we were fortunate and began to see the savings from that, and then the strategy of how to utilize those savings and maintain services or add services to this rural community. When you look at speaking of my rural community, the town that the hospital resides in is a couple thousand people. The 2 counties that we service were less than 18,000 people. So on a daily basis, you're looking at maybe 10,000 people in our service area, and it's very rural. Some of these folks are driving easily 20 minutes to their clinic, maybe longer, depending on where they lived in the county. They were 30, 45 minutes from the hospital. We did have clinics in several of the towns, so we were in the community, the larger communities where our patients resided, and able to make a difference at their local level. And when you think about healthcare and access, the 340B program really brought forward that their access to their medication is very important to their wellness. So that's been my history. I will admit, through the process, we had a great TPA that was very helpful, but I think what really helped us is we were introduced to a group to help us really manage our program.
Yeah.
And that was a group that's local to Mississippi, and they really helped us. You mentioned compliance, and that was my first introduction to them. We had a compliance issue that really helped us through that. And yes, it was a fearful moment. So that's been my history with the 340B program.
Yeah. And Chad, I guess just so everyone understands, because I know that those of us that, like, I live in an hour from Philadelphia, Pennsylvania. We have like 15 hospitals probably within a couple of miles. We cannot complain about the healthcare that we have. So can you tell us a little bit more about what the work of the Rural Health Alliance is? Like, what is that? What does that look like? And then the Center for Rural Health, like, what is the work that you guys are? What's your mission and objective in terms of rural health providers?
Easily the mission is to help our rural hospitals in these rural communities sustain viability in these communities, access to care. I say on a daily basis, networking is probably the biggest thing we do. The Rural Hospital Alliance has 41 members, all but one is less than 50 beds. So on a daily basis, you know, it's a common occurrence. Hey, I need help with finding this, or what do you think about that? Or, you know, the 340B is a great example. Is we're going into a new year. Last year, we strategic planning and identified that advocacy was needed to be our main focus outside of networking, and focus on advocacy for 340B. And it turned out to be a great decision by this group, and has been very helpful. Hopefully will be helpful for this group.
Amazing. And Chad, one of the things that when we first chatted, we talked about, like, you know, there have been different studies and reports and different things that have been public about the impact of manufacturer restrictions on the, you know, rural healthcare providers. What are some of the things that you have heard from the 40 plus members in the Rural Health Alliance in terms of what the impact of the manufacturer restrictions have caused, you know, to, you know, rural health providers for whom, like, it's not cliche to say the 340B program is probably keeping the doors open in a very real way. I don't know if you agree with that. That's my opinion from my, you know, my perspective in working with rural health providers. But what has been their experience in dealing with these, you know, manufacturer restrictions and challenges and things of that sort?
You just described it. You know, many of these rural communities and rural providers, the 340B program does generate a lot of savings and a lot of dollars that has allowed these hospitals, through their rural health clinics, through their relationships with these local pharmacists, to continue to provide access to care. And, you know, in my conversations with some of these rural community hospital administrators, you know, they've been able to develop infusion therapy programs because of the 340B program. I was visiting with an administrator the other day, and, you know, he's implemented a transportation service specifically through his 340B savings. So these are real services to the people in these communities that are impacting their access to care. Again, go back to, you know, when you just talk about the drug itself, the 340B program provides access to much needed medications for these lower wage indigent folks that wouldn't otherwise be able to afford these drugs. You know, in my career, many times, and I'm sure many folks online, you know, you get out in your community and you're visiting with these people. It's not uncommon to find folks that are making decisions that, look, I'm going to pay, I have to have groceries this month, so I'm only going to get 2 of my medications. So they buy or purchase those 2 medications so that they can buy other things that they need to live. And you think, well, that's not real, or that's just not true. Well, it is true, and it is real, and it happens on a daily basis. So, you know, as a primary care provider in a rural community, you're struggling with a patient that's trying to maintain their diabetes, and they're making a decision on a daily basis of what to purchase, and it's not always their medication to help them maintain their chronic disease. So when the impact is, you know, to the covered entity right away is a loss of revenue. And we've seen hospitals and covered entities that have lost, you know, 50% or greater of these savings. So you take a small critical access hospital in these communities, and you know, maybe the number's $3 million. Well, you know, that's now $1.5 million out of their bottom line, and they were using that $1.5 million to support some service, or to pay the salaries or wages to the nurses to provide that outpatient service or whatever it may be. You know, I think as you talk with hospital administrators, you know, easy for them to right away talk about how it's impacted them. But the more you visit with them and the more they explain, and just what I'm doing today is, you know, in the back of your mind, you never lose sight of the patient. How did this impact the patient? And reality is, for those programs that have a cash discount program that's providing immediate discounts and immediate savings to that patient, it's taken away that ability of that patient again to purchase the medicines they need to maintain or control their chronic disease. You think, you know, I was just reading, you know, the great work that we've done to get this law passed. We're now experiencing the flip side of that coin, and that's the lawsuits that's come with this law. Right now, there are 3 three suits that's been filed. We're expecting a fourth, maybe fifth. And the first hearing's the 27th of this month. So I've been a part of reviewing that and trying to help folks help explain how the 340B program works. So again, the patient itself is experiencing the impact of these restrictions, because now their local pharmacist that was a contract pharmacy is no longer eligible to participate as a contract pharmacy. So now you're asking this patient, 70-year-old patient now to travel 15, 20 miles away. And maybe that doesn't sound like a long distance until you don't either have adequate transportation, or maybe you can't drive and your family doesn't live local. You are able to sustain yourself and live independently in your local community. But when you're asking that person now to travel 15, 20 plus miles away, maybe they can't live independently anymore. So this has a real impact on people.
Right. And before we shift to the Mississippi law itself and everything, the Contract Pharmacy Access Bill, I can say, like, the most rewarding time that I've had in 340B was when I worked at a health center in North Philadelphia, and worked in, I'm sure those of y'all that have seen the pictures of Kensington Avenue and just the drug abuse and the true suffering in communities like that. And I worked at a health center that serviced a community like that, and a lot of great people in those communities. And I remember a time where I had a patient who was paying $100 a month at a large chain. And because of the 340B program, we were able to provide a 90-day supply under our sliding fee scale for like $9 or something like that. I mean, and the lady started like crying. And I still use that as a motivator for, working in 340B. And I'm, at this point, I'm obviously not as close to the patients as I was at a certain point in my career, but that has always been touching to me. That's a hard story to tell for people to really grasp the importance of this program, that it really is like, I don't have $100 to buy this medication for my blood pressure, so I'm not going to take it. Right. But because of 340B, a critical access hospital, a health center, community health center a hospital can then say, hey, we're going to give you this drug at a 340B pricing. And, that's a real thing that happens in communities every day. Yep.
Every day. I agree.
I want to shift gears to talk about the Contract Pharmacy Access Bill, because what you guys have done, which is due to go live and just, go into effect on July 1st, right? Mm-hmm. And now there is, as this world of 340B is changing, like, I don't even know what next month is going to look like. But on July 1st, the bill is due to take effect. I want you to walk through the folks that are in the room. We have a lot of 340B managers, coordinators, director of pharmacies that are watching right now. Kind of, if you could walk us through that journey, like what was that journey like of navigating, like, hearing from your members saying, hey, Chad, this is devastating to us. We're losing 50% of our savings, to what do you do next? How do you even navigate? Who do you go to get to the governor, and you know what I mean, and get the bill passed? Because I find that really fascinating. So I want to kind of hear from you. What was the journey to get that bill to the governor's desk and get that passed? And I want to give you the opportunity to share that, because I think that's so important to this conversation.
Well, the first thing is we collectively work together. So you had 41 hospitals sitting around the table, and I can't say 100% of those participate in the 340B program to the point of a retail pharmacy, but the majority of them do, recognizing that this is an issue and what can we do about that. We had seen Arkansas and Louisiana pass bills. Can we do that? So lots of discussions about what we can do. So then that turned into, what does a draft bill look like, and how do we get that done? I have to give credit to some other folks. They actually had drafted the bill and presented it to the Speaker Pro Tem on the House of Representatives side of our legislature. The bill we had used Louisiana's law as a template, and then amended it to fit into the Mississippi criteria. So as we here were working on the draft, the draft was introduced to the Speaker Pro Tem, which was great, which was fine. We didn't have a problem. So we had other people working on this too. I think the main thing here is collective. You had a group of providers working together to make a change here, or to protect a service that's meaningful to their communities. In that, reaching out to other industries that this impacts, and that's the Independent Pharmacy Association.
Yeah.
And engaging those folks to find out where they are, and are they going to support this? Is it important to them? Already knowing that answer in these rural communities, the independent pharmacies are the contract pharmacies. I was reading something in one of the briefs this morning, and the plaintiffs mentioned large retail chains. Well, that's in the rural communities, we don't work with the large retail chains as much as we work with these independent pharmacists that lives in these communities. So engaging those people and bringing them on board, reaching out to hospitals and providers that are not part of our association. So the FQHC, or the Community Health Center Association, finding out where they are. Outside of that, there was an opportunity for a hearing. The legislator had invited several providers to that hearing. For me, that was a learning curve, because our large teaching institution, hospital, University of Mississippi Medical Center, was involved in the hearing, and listening how they use and utilize the 340B program was very enlightening. And some of our large systems, a couple of the large systems, had presented in the hearing too. The FQHC Association, they were very similar, and his presentation was very similar to how we access and utilize 340B program in our critical access. So that helped me to understand that, hey, this really is a bigger issue, and we need to make sure all these people are on the same page. Once the bill was introduced, then it was a matter of just working with the legislators and educating the legislators. And I think for me, in our group, that's probably where I was most excited. It a setback at first. The bill on the House side was given to a committee and a committee chairman, and one of my hospital members and I went and met with her, and we took some specific data about that hospital. And then one of the 340B managers that operates in the state, that has a handful of clients I know well, had gotten some data from them. So we went prepared to talk about the 340B program, just as we're doing today. Share the story that initially the representative, the chairman, was not is receiving of information about the hospital, because we started talking about the hospital and the critical access hospital and how this impacts the hospital, and wasn't receptive to that. So we pivoted very quickly and transitioned the conversation about the patient. And when we were able to make this about a person, and then talking to her about one of her constituents, a voter, and how this impacts that person, and you're going to make a decision that's going to impact somebody back home. And it's not just your hospital back home and all the people that work for your hospital, it's the people that your hospital serves. So that really changed her approach. That's what, from there on, that's what I've begun to, my conversations with other legislators is really start about the patient, and recognizing that this impacts people on a daily basis, and then rolling that up into how it impacted the hospital. And it's not just the loss of dollars and funds, it's what those hospitals are doing with those funds that may not be available any longer due to this loss. Again, full circle back to the patient. So you've got patients it's going to impact daily right away. It's a loss of funds for that covered entity that could result in loss of services. Again, that's going to impact those patients on a daily basis.
Yeah, that's such a golden nugget. Like, that's such good insight, because you're right that And so, I mean, you were talking about hospitals in Mississippi, right? There's hospitals, in different areas of the country that are not as rural, and have, these nice, buildings and tons of executives and stuff like that, where if you're going there and talking about the hospital lost X amount of money, although that's real and that's going to have real downstream consequences, I think you're right that it's really important to make it about the patient, because the people on the other side are not just claims on a spreadsheet, but they're real people that are getting these medications because of the 340B program and the savings. So that's a really important nugget.
Yeah, I think the other takeaway, and as I learned, the 340B program is such a complicated process. For people like me that's been around it a long time, I'm not a 340B expert. So the other thing I learned quickly, if we wanted to impact their decision making, the legislators' decision making, we needed to educate them as best we could, not get in the weeds.
Yeah.
Help them understand what the program is and how it works. So putting together flow charts of how the patient accessed the hospital, and now it's a patient of the covered entity, and now it goes and actually putting pictures on paper, a one-page just a one-page flyer, and that had an impact. That helped folks that lay people understand how this program works. We ran into some opposition from the manufacturers, and at one point, it was a pretty popular approach from the manufacturers that the 340B savings were used to support illegal aliens and providing free care to illegal aliens. So we had to defend against that, and that these 340B savings are go to patients of these covered entities. It's not just for anybody. They have to have established care. So then we had to educate those kind of things. Again, keeping it on a layperson's level so that they could get their heads around this big process.
Interesting. So talk to me about, because I know time's running out here, and I'm really curious about this. So you said there's 4 countersuits now. So like the bill passed, the governor signed it. It's going to go into effect July 1st. And then after that, I mean, after these types of bills go into effect, then entities are sort of rushing to try to get pricing back on 340B accounts and all these other stuff. And, depending which manufacturers come out and say, we're going to now exempt Mississippi from restrictions. What does the legal process look like over the next couple of weeks for you guys?
Well, it's been very busy. It started this week. So I've been very fortunate to be involved or included in this process. Not being a lawyer, it's a little overwhelming. Again, very busy. As I noted a while ago, the first hearings on the 27th, there was a deadline of Monday of the Attorney General's office of submitting its briefs, and then defendants that are going to support along with the AG, those briefs had to be in. And there's the AbbVie. AbbVie is now suing. So I think those briefs are due Friday or Monday. I'd have to go back and look, but those briefs are due very soon. So right now it's just keeping up with what's going on, and how do we help? And we being the Rural Hospital Alliance, the Mississippi Hospital Association, the American Hospital Association, but on a local level, how do we help? And making sure my members are up to speed as to what's going on, and can they help individually? Can they provide information about their specific program? I'm not sure after the hearings. I don't have a good grasp of what would come. Yeah, I'm not sure.
Yeah, I mean, who knows? This stuff is really unprecedented. I mean, I think you're right. Most of us that have been in the space for a while, you're talking to people who've been in the space for decades, and they're just like, man, we don't know what's going to happen. We don't know if there's going to be federal action, or just don't know what's going to happen. It makes for this question: what message do you have? Just a last question, kind of closing question for you, for those of us that are on the line. I think we will have a little bit of a Q&A session at the end. Maybe, Chad, are you okay with taking 2 or 3 questions? Maybe.
Sure.
I do want to ask you though, what message do you have for the 340B manager, coordinator who's sitting here on this call, on this webinar who's like, I don't even know where to start. I don't even know how I can be helpful. I don't even know how I can really impact something like, getting a bill passed or talking to the House of Representatives of my state. What message would you have for them? Like, how could you encourage them to learn how to navigate something like that?
The quick and easy answer is your association. You know, if you're a critical access hospital, or you're part of a rural hospital association alliance, or you're part of your state's hospital association, all of our state hospital associations have advocacy experts, and they would know how to do that. If you're a manager, starting with your local CEO and talking to them about your interest and what you would like to do, make sure that they're engaged at the state level. Your local legislator, reach out to them, make sure they know, because a lot of times you'll find that, the legislators that are chairmen of these committees are usually your more informed decision makers. So reach out to your local representative, your local senator, make sure that they are aware of how this impacts your local community. I encourage you to talk about their constituents. But that's where I would start. Start with your local folks, start with your CEO, make sure they're on board. Start with your association, and then reach out to your local legislators. Your associations will know how to get a draft of a bill in front of your legislators. Once that starts, I would encourage you to have as much data as you can of how this specifically impacts your organization. And then what are you doing? Because that's the one thing that folks want to know. How are you using these dollars? What are you doing with these savings? So know what you're doing. Have specific examples. If you're providing a service, an infusion therapy service, because of the 340B program, that's an answer. If your administrator, CEO is saying, well, we use it to pay nurses' wages, then that's an answer. Helping maintain the clinic in a local community that's 20 miles away from the hospital, that's an answer. Without 340B savings, that rural health clinic may not be in that community. So know those things and be willing to share those things.
Well, that's amazing. Yeah, good nuggets of information. So you were saying make sure your CEO's on board, your executive team, reach out to your association, and talk to your local representatives. I think those are really, really good tips, especially for those states that don't have even a bill in consideration. I want to say I've been following this. I want to say, for example, the state of Pennsylvania, I think is one that where I'm at that I don't see, at least I have not heard, and that could just be that I'm just not aware or informed. But there are several states where I don't see much movement on something like this. And like you said, some states where, our friends on the other side of pharma are creating narratives and things that are not necessarily correct or true, and unfortunately creating the situation where there's a lot of education that's needed from legislators. And 340B is already complex, so having to educate legislators when they have a million things on their plate is a challenge itself. Chad, thank you so much. This has been, such a 30 minutes just full of so many nuggets of info. And I really hope that everyone that was online today really, really got a lot of that really good information that you shared. Make it about the patient. I think that's kind of like the one message that I was like, oh man, that's gold, of really ensuring that we're thinking about the impact to the patient. Yes, there's going to be impact to the entity itself, that then it's a downstream to the patient, but the patient ultimately will be hurting. The constituent in that community will be hurting because of this, and truly, the contract pharmacy access bills seem to be like the most effective way to fight this at this current moment. So Chad, thank you so much.
You're welcome.
For joining. I got just like 3 quick questions for you. I'll throw some little fire questions at you real quick, so we don't take too much time. But I got here. Rebecca Crane is asking, what 5 manufacturers have filed suits? So I think you said 4. What are the ones that filed suits against you guys?
Novartis, Pharma itself.
Pharma, okay.
Yep.
That's like the lobby group, right?
Yep. So they filed an individual suit, and then AbbVie has filed suit, and then we believe that Bristol
Myers,
they will file suit.
Wow. Okay. There's a question here from in chat. I don't know if you feel comfortable with this. There's a question here from Sandy Clark who said, "Can we get a copy of the flowcharts that you use to educate your lawmakers? And also, could we have a copy of the legislation? I think the legislation is online. What's the name of the bill? It's HB
House Bill 728.
House Bill 728.
Yeah.
Sandy, I was able to Google it last week. If you Google Mississippi House Bill 728, you should be able to find the legislation. And then chat on the flow chart. I'm not sure. We'll talk about that offline. Just figure out that's something that's appropriate.
And I don't mind sharing. So
okay.
I can email it to you, and
yeah,
you know, it's nothing special. It was pretty generic, but it worked.
Yeah, no, but I think it helps. And then there was a question about what happens on July 1st. So if the bill starts on July 1st, and someone was asking like, hey, in West Virginia, it's only some manufacturers came out and said, we are lifting exemptions. What happens if none of them do, or if some of them, like, do you know how your members are planning on approaching that? Or
well, that's a conversation now, is what do we do if they don't comply? And we know in Arkansas and Louisiana, not everyone complied. So reaching out to them, seeing what their response has been. We do know with West Virginia's situation that because of that, their suits there, that a couple I know one manufacturer has already sent out a letter or notification that they're going to comply come July the 1st. And I'm sorry, I don't remember the name of that company. So what we've seen recently is we do expect some to comply, but we certainly don't expect the majority or all to comply. I think what's going to happen is most are going to sit and watch these lawsuits and see what happens.
Right.
So when you think about in Mississippi and Louisiana, the responsibility of overseeing the compliance falls with the Attorney General's office. So if you've bombarded them with lawsuits, their capacity is right now defending the suits that have been brought to them by the manufacturers. So I think now it's strategy. What do we do? How do we approach the manufacturers? And what's the game plan if they don't respond? I think right now what we can expect is for them to monitor the situations of the suits, and I think they'll take action based on the outcomes.
Okay. So Chad, I don't want to take any more of your time. I know there are people asking here in the chat if they can get your flow charts. So we'll talk about it offline. Maybe we'll send it in an email after. But Chad, I want to thank you so much for joining us today. I want to be respectful of your time. Thank you to everyone that joined. Chad, I don't know if you have any last words, but I'm just really grateful that you were able to join us today.
No, just thank you for inviting me. I appreciate the opportunity to share our story.
Yeah, thank you so much. And
absolutely
wishing you guys the best dealing with all the lawsuit, the lawfare, and all of that.
Yep. Thank you. Appreciate it. Bye-bye.
Bye.